I'm Ezequiel Parodi. I'm a Vascular Surgery Division of Vascular Surgery at the University of North Carolina. I'm an associate professor, and I'm also the program director for the Vascular Surgery Fellowship and the residency. I decided to become a doctor probably late in high school, I have to say. I'm originally from Argentina, so you go straight from high school to whatever career you choose. I look at different options, and of course my father being a physician and a vascular surgeon was an influence to this. In high school I didn't do it that much, but I went and I scrubbed and I watched some surgeries with my father, and I thought it was quite interesting. It takes a while to realize the first time you go there, it's like, oh, that's what my father does every morning and when he goes to work. It was a little bit of a shock, and it was interesting, and I became passionate about this. A vascular surgeon is a pretty broad specialty where, as we all know, we do surgery everywhere in the body, from carotid disease, from AV access in the arms, abdominal, thoracic, thoracoabdominal aneurysms, occlusive disease, there are aneurysms in their lower extremities, or occlusive disease. So we do surgery everywhere. We do a lot of open procedures, endovascular procedures, and hybrid procedures where we do part open, part endovascular. I love doing all of these surgeries. I specialize mainly in something I've been doing for years in the treatment of thoracoabdominal aneurysms, either endovascular or open. I have a lot of interest in carotid disease and some occlusive disease as well. I treat aneurysms of the aorta. The aorta is a main artery taking blood all over your body. It starts from your heart and it goes all over. And some patients, there's a permanent dilation of the aorta, and that's called an aneurysm, and when the aneurysm is big enough, it can eventually rupture. Two different ways of treating these aneurysms, either with open surgery or endovascular surgery, which is navigating inside the arteries and being able to fix this in a minimally invasive way from the inside of the artery. We're going to decide what kind of approach we're going to take depending on our patients. We treat a lot of patients who are elderly, who 20 years ago had no options, and now we can treat these patients, again, minimally invasive, safely, just going percutaneous through the groins and putting some special stents that accommodate to the patient's anatomy. I want my patients to know that even if we spend 20 minutes, 30 minutes in our clinic, there's a lot that happened before that, and there's a lot that happens after that. We're talking about decades of training, working hard to get to the point where you are, where you have the experience and knowledge to be able to treat patients safely. A lot that happens also after they leave our clinic. There's a lot of planning, especially looking into image, devices, make sure we're going to have the best options for our patients. When I walk into a room, I want to make sure our patients understand what's going on. I have to say, and it's difficult to some of these complex problems, so what I do every time is I have a diagram of the aorta, and I draw and make it clear to now understand where is this in their body, what are our options, and what's my plan, and where is their aneurysm, and what's going to be the best way to take care of it. It's quite complex. I don't expect people to understand 100%, but they need to have an idea why are we doing this, and what are the risks, of course, and of course the benefits, and what we can offer to them.